Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. Thanks for joining me, Lucas and Drew. We will go ahead and jump right into the good stuff here. I've started a little trend of an icebreaker, and I don't believe Drew has gotten one yet. So, Drew, what is your favorite candy? Let's say you're making a stop at a rest stop on a long trip. Got to get some sugar to provide a little bit more energy. What are you picking up there?
Yeah, can I say anything about the time we went all the way to Tennessee and we stopped at
This is an
oh
easy question. It
Easy.
is
Let's hear it.
sweetheart ropes, like hands
wait,
down.
what?
Yes.
Fair enough.
We stopped at Bucky's. It was Drew's first Bucky's experience
There we
ever.
go.
True.
You can open up a whole another case with that, but we will.
Yeah, for some at Bucky's, like brisket sandwiches. Can that be a snack?
Fair enough.
That's
45 minutes later, you got your arms full of a bunch of different things. So,
That's right.
Oh man.
all right. So today, I want to give a shout out to Sean Dugan for his question that prompted this episode, and we're looking at low back pain, specifically kind of in the categories of facet versus radicular symptoms. And what we want to do is kind of open that up. This may be a two-part episode, so we'll kind of see where we get to here. But Lucas, let's start off with you. When we're looking at low back pain, some of it may be referred or not below the leg. We're trying to differentiate between these things. Open up to you. What comes to mind?
So we're talking about radiculopathy versus the facet syndrome, correct? Yes.
Correct.
The main differentiator here is radiculopathy is a nerve symptom, right? As a nerve symptom is not your dull ache situation ever. If it's a true radiculopathy, it's going to be more of a sizzling, like a toothache, and it's deep in the core of the bone that the patient is going to refer. Another easy way to differentiate between these two is facet would be a refer symptom, not a radicular symptom, right? So the radicular symptom is that what I just said. On a referred symptom, could be more of an aching, dull, throbbing that goes down to below the glute fold. Radicular symptom won't be localized in the back only. It will be down below the gluteal fold. A referred symptoms may or may not be below the gluteal fold, and that is where I also throw in the middle of the quote-unquote SI joint dysfunctions, because the L5 will refer to the SI joint.
Yeah, so when we're looking at those two, really distinguishing between kind of that hot sizzle, shooting pain, you however, not typically going to see it localized into the low back when you're looking at radicular versus the referred, kind of looking a little more ache,
Right.
or gnaw type discomfort. You can potentially have some of the low back pain as well too with that, as what
Right.
you're going to typically see. And obviously, these are all typicals. Patients don't read textbooks, but when you're trying to differentiate out, seeing that as well too. So, we got. How about you, Drew? What are you seeing when it comes to this?
So if those are kind of on my hypothesis list. I'm typically going into my objective exam and thinking about how do I differentiate the neurogenic versus more nociceptive. Like those would be the two things I want to differentiate between. And I think pretty easily you're going to start to see a lot of the nerve tension with. Typically, I prefer to do like a straight leg raise, just because the slump has a lot of lumbar movement, a little bit more lumbar movement, and that can affect all of them. So if you are thinking it wants to be specifically more to the nerve and differentiating between that and the facet, I'm going to try to keep it more stable by keeping them supine. So that's going to be one of my biggest go-to. Is this more nerve related or is this more like a somatic referral from the lumbar spine?
All right, so using some of the tensioner tests to try and differentiate between the two for you, Drew, is correct.
Yeah.
How about you, Lucas? What else are you digging into in the objective measures as you're trying to work between these two?
Straight leg raise unilateral versus contralateral, because now we're also thinking about the scogenetic, right? Back to the subjective is a constant pain. Neurological pain is a constant pain. It doesn't come and go. It's usually relative to an inflammatory process. So that's a constant pain. It can change overnight versus morning, but it doesn't go down to there's a period of the day I don't have pain. Whereas the facet, if you're resting, relaxing, very well will have no pain at some points, especially when you unload, right? The facet syndrome is a syndrome because the proximal and the distal facet are jamming against each other, creating that symptom, right? So the moment you unload it, pain's gone. And the radicular symptom, the patient is going to suffer all night long. Is a throbbing, lancinating, all night long kind of situation. They may or may not find a specific position that helps, but that's not always the case.
You'll also see like a fair amount of latency there. So like you could be doing something and it might seem okay, and then for no reason later on it just gets super flared up.
Yeah.
That's maybe not necessarily all that mechanical. That would also indicate a lot more
Yeah.
of like a nerve type pain.
Very good point.
Absolutely. And as you're looking at kind of muscle testing, reflexes, what else are you going to see between these two?
Decreasing reflexes, like decreasing DTR, specifically in the dermatome myotome that you're talking about here, right? And that's important to note that the dermatome myotome follows specific rules on the radicular symptoms, whereas in the facet doesn't really. There's a crossover of dermatomes there. And I think the objective evaluation is 2 or 3 tests. It's specifically the trade leg race that I'm going to stick mostly with. The functional gait analysis will also be telling.
Yeah, I think there's like it can also depend on the irritability of that one, because I've seen numerous times where I do think there's some sort of a neurogenic type symptom, but if I'm just doing dermatomes, myotomes, and sensation, it's not it doesn't jump out drastically, unless you go really into it. Um, that's where you could probably make sure that you're doing these really well, making sure that you're doing long enough hold for myotomes, giving the right instructions, doing a good sensory exam, and then even the reflexes often seem to be one of the last things that I see good, dependent on the irritability. So usually, if the irritability is, or if there's a loss of reflex, usually the irritability is or has been really high, or it's been a pretty significant injury to the nerve.
I think that's a good measure there as well too. So, Lucas, what's just some quick clinical pearls on more likely the acute radiculopathy that's in? What are some things you're doing to get this patient out of pain, get him feeling a little bit better?
Either Mackenzie or Maitland. Mackenzie, if you find a considerable shift that describe that can correlate with that symptom, the shift will probably be contralateral. You work on the shift. Every time you have a shift, you work on the shift first before you work flexion or extension. This is Mackenzie. On the Maitland, whether it's a youngster or a senior patient, I prefer to start with gapping mobilizations to help both facet and radicular symptoms.
All right, and Drew, you got a patient that you are suspecting the more the facet syndrome, if you will. What are you starting off with day one in the clinic?
So with that, I'm probably thinking more the manual techniques of try to improve their mobility, whether it be um, a manipulation, mobilization, something like that, to create again a window of opportunity that they can move better to ease those symptoms. often I'll find that using that in combination with some sort of like mobility, or sorry, a neuromuscular type core stability type exercise is going to be pretty good. So using the whatever new range they have through the full range pretty quickly, like, and then maintain it as much as you can.
Yeah. Good stuff. Anybody got any other closing thoughts on this topic before we
Uh,
put it down for the moment?
in addition to that, I'll say I'll
Yeah.
keep going on with that. I think that I've seen a fair amount of times where repeated movements, even the McKenzie approach, can be a good use for, even if it is facet. Um, I don't only use that for radicular pain if it's centralizing. A lot of times that can help just improve mobility, motion, and decrease pain, even if it is maybe like a facet. If you find the right type of movement that helps calm it down and ease it, even if it's not centralizing, you can have a decrease in pain and improved mobility as well with that. So don't forget about McKenzie type things, even if it's not a radicular thing.
And back to the manipulation that Drew mentioned, remember the sooner you do, the better. Below the knee symptoms have quite a strong contraindication or precaution, if you will, at that point. I wouldn't shy away from doing it, especially if I'm working on a thoracolumbar, for example, manipulation.
Yeah, it's good stuff, guys. I think a lot of it still boils down at the end of the day, getting your patient moving and getting them comfortable a little bit, and a lot of it tends to take care of itself. So, but I really do appreciate differentiating these two. I think it's really helpful. Again, Sean, thank you so much for the question, and keep them coming, guys. This is something that we want to be a consistent. Anything you guys are seeing or you want to dig a little bit deeper, we'll break down and dive in a little more. So appreciate it, Lucas. Appreciate it, Drew. Looking forward to the next time. See you guys later.
Thank you.